Welcome everybody to the Random Anesthesia Topic podcast. In this episode we have Dr. Natasha Bartel from King's Animal Hospital in Ontario, Dr. Ryan Bailey from Premier Veterinary Group in Chicago, and I'm Dr. Gianluca Bini, owner and founder of Safe Pet Anesthesia, a training and teleconsulting company, and I'm an assistant professor of anesthesia and analgesia at Oklahoma State University. Let's get started. All right, tonight we have with us Dr. Mika Hamilton, which is an assistant professor at the University of Toronto and a staff anesthesiologist and intensivist at University Health Network. Thank you again for coming back. We didn't scare you away, so that's great. So I think tonight you have some questions for us. I have a bunch of questions for you. Tasha has some for you as well.
And I'm just along for the ride.
Yay. You're just here, hot dog guy.
Yeah.
So, fan fact, I spoke with one of our clients and figured out that her best hot dog was in the stand in Reykjavik. And I was like, this is endless. I was like, this is now the third person in 3 months.
I'm going to need to
get this hot dog stand to sponsor us.
What's that Iceland airline that goes to Europe that like you always have to stop over in Reykjavik and then go on to? That's what I just need to.
Iceland Air is Iceland Air.
No, I just need to make sure to book my next trip on Iceland Air just so I can stop in and get this hot dog.
I think they actively encourage it, to be honest.
Yeah, we should. I mean, at this point.
No, it's a free stopover. Like you go to the lagoons and then you go for the hot dogs and you're out of there.
Or just go for the hot dogs.
I'm sure it's been done.
Yeah, she was showing me a picture and she was like, yeah, this is amazing. And I was like, wow, okay, so that's real.
So
that's awesome.
When I was there, we went on like a walking tour, and the tour guide actually said, right now I'm going to take you to look at one of the best restaurants that we have in Reykjavik. And he walked us over to this building, and there was a restaurant in there, and I think it's in the Michelin Guide, and it's super fancy. And he stood at the door, and then he said, I want you all to turn around. And we all turned around, and the hot dog stand was there, and he was like, that's it. That's the best restaurant.
Oh my God. I would have just dropped dead. I would just drop dead on the spot and just like.
Yeah, bravo. I think he drums up a lot of business. I don't even know if he needs to drum up business. I'm sure they get enough business. So.
It feels like the Reykjavik tourism office is just doing a lot of work for this one hot dog stand. It seems like everyone's really just trying to divert all the business in Iceland to this hot dog stand, which, awesome.
Yeah. That's amazing. All right, Tasha, I think you had a lot of questions for Dr. Hamilton. I don't know if you want to start.
Oh, well, yeah, we actually, in between our sessions, Dr. Hamilton, we recorded one on ventilation, which led to a question amongst the three of us about how often when we have pulmonary compromised patients, or how much do we perceive that inhalant versus total intravenous anesthesia is appropriate. And then I gave one of my examples was that when I did my human anesthesia rotations, I participated for a few days on the burn unit in Manhattan. And, a lot of those, actually 100% of those patients received Teva, regardless of whether or not, because one of the thought process was I would understand if you, for example, had smoke inhalation. But even the ones that was like localized burn were receiving Teva. And I was wondering, like, I don't know how much burn work that you've done per se. Are you familiar with it? Do you agree that in the cases of either smoke inhalation or pulmonary compromise, that Teva is the way to go? How much do you worry about hypoxic pulmonary vasoconstriction associated with inhalants? Mm-hmm. That's really our thought process.
So I don't do burns, currently. I think the last time I did burn anesthesia was actually when I was a trainee back in the UK. But from what I understand, I don't know that burns in particular are a really strong indication for Teva with regards to the hypoxic pulmonary vasoconstriction. I think it's more like there's like theoretically and physiologically it makes sense, but likely in actual practice, it's probably equivocal. And again, I think it goes back a bit to what we talked about last time. Is I think it can be very just center dependent, anesthesiologist specific. So I think that would be my understanding of it. I mean, we have like lots of uses for Teva, but I'm not aware that like burns anesthesia is a really, really strong indication. I'm sure you could argue for and against, and I'm sure you can argue for and against volatile anesthesia because, I always say if you ask 10 different anesthesiologists, you'll get 10 different answers, So
We like to ask 100. We always say ask 100.
Maybe,
So,
yeah.
okay. So your answer is classic
Yeah.
anesthesia, which is totally wishy-washy, which is exactly how we feel. Yeah. Yeah. We rarely find like there's hard and fast rules or one thing is right and one thing is wrong. And I get very upregulated about when someone says something is safer per se what does the term safer even mean? But yeah. Okay. Interesting.
I think safer also depends on what you're familiar with using, So maybe like your technique is a technique that someone else may argue is not the optimal technique, but if that was what you're more familiar with and what you use more in practice, that may actually be, a safer technique for you and that patient rather to then try something new just because someone else told you should, So I think it's all very context specific.
Yeah.
Okay.
I think a lot of the times, like, especially, I'm sure that this happens to you guys too. Like, when we go speak at conferences and whatnot, the attendees come up to you after, and the typical question is like, "What's your favorite protocol? Or what's the safest protocol?" And I'm like, 99% of patients, it doesn't matter. Right?
Yeah.
Like in 99% of patients, like as long as you stay within the dose range, whether you pick, propofol ketamine or propofol midazolam ketamine, and like, if you want to do, I mean, I guess you guys don't have Alfaxalone. We do. Fortunately, it's a neurosteroid induction agent.
Mika, are you familiar at all with Alfaxalone?
I
Ooh,
am in my head thinking, what is Alfaxalone?
Oh, yeah, no, it's a monster drug in veterinary anesthesia.
Monster drug.
It is. I mean, it's probably the primary induction agent out with propofol. So, yeah.
Yeah. So it was developed in the 70s and it was released in both humans and veterinary medicine. In humans it was a combination of Alfaxone and Alfadolone, and it was sold under the name Altessin in humans and Safan,
Yeah.
I think, in veterinary medicine, or vice versa. I don't remember. But anyway,
Oh, you're right. You're right.
but at that time they they picked as a media
Camphor oil. Camphor oil.
Camphor.
It was in camphor.
there was crapload of anaphylactic reactions, and so I think it lasted on the market a few months and then they withdrew it. And then in the 2000s, an Australian company, Jurox, came out with alfaxalone alone in beta cyclodextrin. Now, in humans, I think they are in phase 3 clinical trials in Australia with a different kind of cyclodextrin, because I think 90% of humans are allergic to beta cyclodextrin specifically. And so, but I don't know I don't think they made it to the market in Australia either, but they're definitely in clinical trials of it.
Okay. I'll look out for it.
Yeah, it's a neuroactive steroid, Mika. It, like everything else, works at GABA sub A receptors. So the one major differentiation, for example, between Alfaxalone and propofol, I'm almost afraid to say anything about Alfaxalone and propofol, but Alfaxalone you can either administer IV or IM. So that has a really nice usage for us, because when things are really going fractiously we'll call it. It's easier to slow something down for an IV catheter if you poke them IM, obviously. So commonly used, in dogs and cats for that reason. Can be volume limiting though, just because of the concentration. So for example, works really nicely in pigs, but you'd have to give like 50 mils, which IM is never going to happen unless you really feel like being run into a wall by a pig. So, but anyway, yeah, no, I was just curious whether or not it's very veterinary specific, but I didn't know if it had actually trickled over and like you guys, had some analog in development, like John Lucas said, or whether or not you'd ever heard of it. But
I mean, I'm sure some people have heard of it, or maybe some people have used the original formulation in the 70s, but that was a little before my time. So
I think it's before everybody's time on this.
yeah, I think
well,
so.
I mean, I think we're all from the 1900s, aren't we? We're all from the 1900s, but I was definitely not at the university level in the 70s. Woo.
No.
Okay.
But yeah, so I mean, besides that, do you feel like, we were talking also on the last ventilation episode about pulmonary hypertension, right? So
Mm.
you guys obviously have better tools to fight it than we do. Like, you have like nitric oxide blenders, all that, which we don't really have access to in veterinary medicine. Is there anything you would, if you didn't have a nitric oxide blender, is there anything you would, what would you do on these cases?
Well, it's always beware the right ventricle, so because it can turn in an instant. So I think with these cases, I mean, we have also peripheral hospitals here that also don't have access to nitric oxide, prostacyclin. So I think it's about going kind of back to basic principles, like what are you trying to avoid in pulmonary hypertension? You've got likely a right ventricle that's already quite precarious and very dependent on its circulation. And then you've got pulmonary vascular resistance that you do not want to go up at all. And unfortunately, a lot of the things we do with induction of anesthesia and perioperatively makes that happen. So for like in my practice, when I've anesthetized pulmonary hypertension patients, it's a case of thinking about, perfusion to the right ventricle, maintaining normoxia, not letting the patient get hypercapnic or acidotic. Temperature control you have to think about as well, but generally unlikely to happen at your induction point too. And then thinking about, well, what happens when I intubate the patient, and then what happens when I start ventilating them. So, you want to do a nice, smooth, cardiostable intubation that doesn't drop your systemic pressure, but also you don't want to do it in a half paralyzed patient where then you get coughing and bucking, and that's going to kick up your pulmonary vascular resistance as well and caused by hemodynamic shifts. And these patients, people get nervous about these patients as well, and I sometimes see a tendency, when the patient's intubated and things are going well so far, is people are like, yes, and they start ventilating the patient and they're like huge tidal volumes, and that's just going to increase your alveolar pressure and also increase your pulmonary vascular resistance as well. So I think smooth is the term, and it's about just going back to basic kind of physiologic like principles. But I was also quite lucky when I was doing those cases. Like I worked in a center where we had, like pulmonary artery catheter. So for those patients who were particularly, precarious or with this severe pulmonary hypertension, we could actually look at the pulmonary artery pressures as we were doing what we were doing. And essentially it was, these patients would make sure they had a big IV in before we started. We'd generally have norepinephrine running prior to induction. And, you can argue which is the best vasopressor and which is the best inotrope in these patients. They all have their pros and cons. But in practice, and again, this goes back to what's most used in your center, because the whole vasopressor inotrope argument always, it can be just very center specific. It's about what are you used to using? Should you use a new drug that you're not that familiar with just because someone else said it was better? So we would generally use norepi just to try and maintain the systemic vascular resistance and have that running with the induction of anesthesia and with the luxury of seeing your systemic pressure, your pulmonary artery pressure, and your ventilation pressures, your peak pressures, etc. So
That must be nice.
it's yeah, that is the benefit of working in a big hospital, and I recognize that not everybody has
Must be nice.
that. So
I feel like we should also preface, though, a little bit about pulmonary hypertension in our patients. It's like we get very anxious about it because when they do bad, they do exceptionally bad. But like the vast majority of dogs with pulmonary hypertension that we see
mhm.
are doing like we anesthetize them for whatever it needs. It's not like it's, whatever. And they're just like these giant nothing burgers that we do nothing special, like fairly standard anesthetic plan, whatever preferences you have kind of end up falling into place. And sometimes they need ventilation, sometimes they don't. And like it's this weird thing that our literature is so sparse, and so we always grab from the human side to be like,
Mhm.
how do they manage these PH patients? Because when we've had them, they're really scarring for all of us. But there's so many, like we've probably anesthetized 95% of them, and it's like the only reason we knew they had PH is because they had an echo coming in, but nothing during the case would have said this
Right.
dog has anything wrong with it. It's like it's this very weird world for us of like it's something we perseverate over and then snooze fest.
So do you change your management for those patients then, or do you just do your standard safe technique?
Depends on how severe it is, I guess. Like if they're in the more severely affected patients who are like collapsing at home, because oftentimes the presenting complaint for these dogs is they're collapsing at home during exercise. They usually come in for us. If they come in with a diagnosis, they're usually coming in on sildenafil. So we make sure they get that. I think as far as technique goes, it would depend on the procedure. I think most of us are probably going to reach for some sort of MAC reduction agent if, it's a dog. So it's probably going to be either like opioid or Teva specific. Having ventilation available at the bed and making sure their CO2 stay relatively normal. Pressers, I don't know if we have a consensus within the group on like at least within the three of us. I don't know. I would imagine all of us are probably going to start norepi, but like where I trained as a resident, we all started like dopamine was our preferred pressor agent, so we started dopamine
I was trained on phenylephrine
for PH cases.
for almost everything.
Oh, right. That's so weird. I forgot.
Cornell.
Yeah,
Yeah,
it's so
Cornell has a phenylephrine thing.
yeah. So yeah, that would be my standard, but like there's lots of dogs who are going under anesthesia with pH and like probably no one's the wiser because
Mm.
they're not collapsing at home. And it tends towards like the little white fluffy dogs, I think. Like those are represented.
Or the bulldogs.
Oh yeah.
Bulldogs?
Yeah, I seem to, maybe it's a Canadian bulldog thing. I don't
Yeah.
know. But
I feel
pH,
them as pulmonic stenosis, but
that as well.
yeah,
But yeah, no, if I'm going to see like pulmonary hypertension and something that's really decompensated, it's in like an obstructive bulldog patient for the most part.
makes sense. Yeah.
Yeah. And those ones turn blue at the best of times. So,
Is that purely because of their anatomy, like the way that they're bred,
yeah.
which has kind of resulted in, I guess, one of many defects now? But
Yeah, so basically they're bred for the maxilla to be recessed, but
yeah,
not the mandible. And then the issue is that the soft tissue, like the oropharyngeal soft tissue, has not like allometrically scaled down with this failure of the maxilla. Like, and along with that, like you also get, aside from the fact that they have this truncated face, like they have stenotic nares or nasal passages, their saccules tend to invert. They may have, the biggest issue is that their soft palate constantly obstructs. And that can also lead to like other really horrible complications, like you can get laryngeal collapse or laryngeal dysfunction, or even like myomalacia, like of the cartilaginous structures there. So it really depends on how severe they are. But bulldogs, obviously, classic. Persian cat, classic. Shih Tzus, Lhasa Apsos, pugs.
Yeah.
I specifically have a general dislike for anesthetizing pugs. So they're harder to intubate. They might have a hypoplastic trachea. So like you could have like a 40-kilo English bulldog and put like a size 5 tube in it, which would be, very disproportionate compared to the other breeds. But yeah, and then on top of that, they also are prone to various cardiac insufficiencies. And then on top of that, they're also prone to various GI insufficiencies or GI dysfunction. So they're just these obstructive, regurgitating, diseased skin that you can't get a catheter through, cardiac failure, back problem, joint problem, skin problem. Just bulldogs are definitely the poster child in veterinary anesthesia of high risk. That's the worst.
Mhm.
That's the worst for
Mhm.
everybody.
Yeah.
So you have like a bulldog scale rating of anesthetic risk.
Yeah, we score like how bad their brachycephalism is, right? So like mild, moderate, severe.
Mhm.
And then sometimes like we'll look and we'll be like, we get really excited because they're like, look, he kind of has a nose. Like it could be worse. Or like maybe they only snore, for example, when they're asleep, but some of them, like French bulldogs or whatever, like you, as they walk by you can actually hear them like obstructing, like that is
Yeah.
like the classic like excited bulldog noise, and you're like, here we go, and you just follow them around with a laryngoscope and an endotracheal tube like all day long. So yeah, I think, like, don't you guys think though that brachycephalic dogs do a lot better than cats? No, sorry, do a lot worse than cats. Like I don't have
Oh,
that
yeah.
many. Yeah,
Oh,
like
yeah.
I mean, a Persian, fine, it doesn't have a face, but I don't see them like try to acutely die
Yeah,
the way
no,
that the
no.
brachycephalic dogs do. Like
No,
they're
not at all. The cats do fine for whatever.
Yeah.
They just behave like regular annoying cats, but
Yeah.
they don't obstruct their airways. Like
And
I don't
also
know.
they don't tend to regurgitate.
That's
You know,
true.
true.
that's a big,
Yeah.
and unfortunately, I don't know if you have any, miracle protocol slash drug, but we don't. There is no drug that, at least in veterinary medicine, has been ever proven to improve regurgitation. Like, we have plenty of drugs that treat nausea, they treat emesis, but they don't specifically treat regurgitation. And so, do you have any miracle solution in humans, or
I'm trying to, I'm thinking of all of our pro motility drugs, things like domperidone, but that is just not really something we use in the perioperative setting. I remember when I was doing obstetric anesthesia, we would give the patients like sodium citrate to drink if they were coming in for an emergency C-section because of the higher risk of regurgitation. And that wasn't to stop it, that was just to make it hopefully
We
less
used to,
acidic,
that's another weird
Yeah.
Cornell thing, is that all of the Cornell patients had to receive sodium citrate orally, which is a little harder in dogs because you can't tell them to drink this cup. Like you actually have to syringe it into their mouth, and then you
Yeah.
get sticky grape everywhere. But yeah, we used to do sodium citrate all the time.
One of the things we are dealing with right now is that more and more patients are taking the drugs like Ozempic, which really does increase your regurgitation risk. So, and again, and it's interesting because the guidelines about it have been kind of going back and forward over the last year. So initially, we were telling patients to stop taking it for 3 weeks. Now we're telling patients to take it as normal, but for the 24 hours before your surgery, the fasting is different. So it would be essentially 24 hours of clear fluids pre-op, as opposed to, 2 to 4 hours, depending on where you work. Pre-op, we would do the whole 24 hours. And some places are also, I don't know if this is something that you do in your practice, but some places, including where I work, are employing the use of gastric ultrasound more to actually see if someone's stomach is full or empty, to make an estimation of risk. So if, say, someone had come in and they'd had specific fasting instructions and they're on, one of the Ozempic-like drugs, but, they get a lot of information before the surgery. So sometimes, it gets missed, then we would use gastric ultrasound in the morning to be like, okay, is your stomach empty or full? If it's full, how full is it? And then make a decision around, okay, should we be cancelling this patient and bringing them back? Should we? And also depends on what surgery they're coming in for as well, because it's benefits and risks. Should we be proceeding but using like a rapid sequence technique to try and reduce aspiration? Do we push them to the end of the day to allow more time? So that's something that's really presenting a lot over the last couple of years. So, but again, no, that would be amazing to have a drug that just flushes it.
Let me tell you, you catch a case of Giardia, it'll really shoot things right through for you.
I was just thinking maybe some food poisoning, but
I think one of us has
not
some
ideal.
experience with that.
Yeah.
Oh, that's really interesting. Yes, because that class of drugs has not percolated down yet, and I don't think necessarily will per se. I mean, maybe in the cases of like diabetic management, but nothing in veterinary medicine that's really hit the mainstream. Mika, do you have any questions that you're storing up? Because I know last time we didn't get through your list. We should give you a turn.
Okay, so I'm gonna put the glasses on again.
Glasses on.
It feels so official.
I love how Mika looks so like professional, and the three of us are just like in t-shirts, just like talking about hot dogs and like being hot messes, and like, okay, fine.
Chicago Bears.
Oh, you should have seen me an hour ago, so I don't always look at that. Okay. Oh, okay. So one of my colleagues asked, "What is your essential monitor in the operating room? Like, if you had one monitor."
Oh my God! Don't ask Ryan.
What could you not live without? And are there any animals where specific monitoring is difficult? Like, say, pulse oximeter. But what's the favorite first?
Shit in our field. Like, it's just straight up dog shit.
I think, Mika, like it just, one of the important considerations is what like family of animals you're coming from. So are you a fish, a reptile, a bird, or a mammal, or an amphibian? I mean, I think you guys will agree that anything really small, and I mean like 35 grams small, so like sugar gliders, budgies, mice, things like that, we don't actually have any devices that are calibrated or are scaled to monitor that size patient appropriately, because we're just pinching from human medicine. So, for example, like when you have a sugar glider, I just secure like the Doppler probe over the entire heart. And so all I'm doing is I'm listening for the heart rate of like 280, which is, and I can't put a cuff around anything because it would kill them. Right. So I'm not using the Doppler for actual blood pressure. I'm just listening it for like proof of general life. But the pulse oximeter would like clamp the whole arm and make it would just become like avascular. So an ECG, for example, like in reptiles, like trying to go through scales, and or amphibians, which have incredibly delicate skin, and they actually respire through their skin. You have to be cognizant. So, for example, in those cases, instead of like clamping alligator clips or putting pads on, I might actually just put like a small gauge needle through the skin to minimize the damage, and then clamp to the needle. Let's see what else. Like we don't even.
Reptiles have the whole like their hearts can beat well after they're dead. So like if you're using like a Doppler, like I worked at a zoo for a while doing anesthesia there, and like they would ask me how the reptile was doing, and my joke was always, well,
who knows?
The heart's beating, but I can't tell you anything more than that. Maybe dead, may not be. Who knows? And so yeah, it was like a whole nother set of problems.
I always find that reptiles go a really weird brown purple shade when they die. And other than that, I just assume proof of life. But yeah, so we can actually use a lot of the monitoring equipment. Like,
I mean, even in dogs and cats, we are using a lot of things that are derived from human medicine, right? Like your pulse ox clips, a lot of the times they're, even in cats, they're messing up with your circulation on the tongue. We usually use the tongue a lot for pulse ox rather than,
And if they're digitally shaped for people, like you can't use them for anything in vet med.
Although,
So
like, the newer monitors are much better at that. Like a lot of the monitors that we all grew up kind of using in our residencies were some of the older, probably from the 80s and 90s. They're just not as sensitive. But the new, like for us, the new like Massimo Rainbows do have a much better ability to pick
Yes.
up even in our like teeny tiny little patients, or we have like just this little bit of tongue, or we like can somehow miraculously get it around like a pink cat toe bean or whatever. We actually get information where like the old stuff is like you were lucky to get anything out of it, and most of the time was just a crapshoot. And then like the
a
other
horse
thing,
tongue is like that thick, and a pulse ox only opens like that much,
yeah.
right? So
The other thing is all the clips, the reflectance clips are so big. Like the Massimo like reflectance clip is fucking
The one
massive.
that he's referring to your forehead sensor.
Oh,
So that's what they use it in humans for.
yeah.
What we do is this is my favorite kind of pulse probe. So you shave below the paw pad, and basically you just place it against it, and then you wrap it.
Mm-hmm.
Or in the mouth.
So,
Yeah.
but you guys use it as a forehead sensor.
Yeah, so we'll usually, first line is usually the finger or the toe, but if the patient's kind of peripherally shut down or super cold, you might not get a read in there. So then we've got little earlobe clips, and those clips can
That's the
actually
best one.
go, yeah, and they can go in the nose as well. I've seen sometimes people put them like in the kind of buccal area here too, and then we have I would say maybe more on ICU. I've seen these used as the forehead monitor as well.
you
So.
should take back to your team that sometimes we use like the prep use. So we'll use a preputial skin fold. If we have very hairy patients, or really like stubby little toes, or like there's someone's working on the head and so we can't access the tongue, I often use like the inguinal, like that pre-curl skin fold right there in front of the leg, or you put it on the vulva or the prepuce. So just food for thought for humans. You'll be like, you'll never believe where those vets put the pulse ox.
I might get pulled into my chief's office if I did that.
But I would
So,
like to
Dr.
bring. Sorry,
Beanie, what's your favorite modality of your desert island?
I was
We're not asking Dr. Bailey that question because his
I was
answers
going
are
back to that exactly. So we asked ourselves that question a few episodes ago, and I went with pulse ox,
Mhm.
and I got a lot of shit for it.
The
Not
worst.
as much shit as Ryan.
That's true. That's
Ashley
true.
went with capnograph, which
I
I
went with
think
end
is
tidal CO2, like
totally fair. But
smart.
Ryan went with a Doppler.
Ooh.
Because he's from the 1900s.
Yeah, when you talk about
I worked with Staffan back in the day.
monitors from the 70s and 80s, Ryan, talk about your monitors.
Hey,
In the States, we had brand new monitors all the time.
I didn't grow up on some weird backhanded monitors like during residency. Like we had nice German monitors. Yeah, like, yeah. Whoa.
Hey, you can put a Doppler on like almost any animal that we anesthetize. So, for a
And, like,
desert island.
how are you using it? Is it like continuous, or are you checking in every few minutes? Where are you putting it?
So for dogs and cats, we usually put it on the no, not yeah. I guess it's a dorsal palmar artery, right?
Mhm.
In the dog. So like under their forearm, like right near the paw pad, and then put your blood pressure cuff above it. And then I like it. I think it's a great monitor for your really super critical ones, because you at least get, if you know they're small and it's annoying, you can at least put that on, at least hear the heart beating, so you can feel some level of confidence. If they're too small or peripherally vasoconstricted and you couldn't get the art line in, and it's been 15 minutes and you're starting to sweat and things are going poorly, and you want to get, it's like, how long do you keep the case asleep
Mhm.
while trying to instrument it versus like just get the thing over with. And like it works in like everything. Like you can put a Doppler on everything. Like
Yeah, that is true.
Sure, I
I
could
can't
put
think
a
of an
Doppler on the
animal.
sofa, Bailey. That's not going to help, is it?
I can't think of an animal I haven't been able to put a Doppler on. In all honesty, you can
Can't
at
you
least put it on.
use end-tidal CO2 like a
Sure.
grown-up?
Sure. As Dee was asking the question, I was like, you know what? I probably would prefer capnography because you get CO2, you get gas analysis, you got it all.
Cardiac output.
Sure.
Mika, how about you? Like, because you have to also remember we don't put art lines in all of our cases. Like, I
Yeah.
wouldn't necessarily put an arterial catheter in like a dog neuter. But,
I did though.
why does that not surprise me? But yeah, what's your preferred then?
I'm in the CO2 club. So the way I see it is your CO2, it shows that you've got a patent airway in place, which is obviously very important. And it shows that it shows you've got metabolism. You're actually making CO2, so you must be delivering enough oxygen to make CO2. So that would be my gold standard. And it's, like we have to use it in the operating room. We're using it on the ICU now as well in all of our intubated patients. Because, when your CO2 disappears, you very quickly know that there's a problem. There's either a problem with your tube, with your circuit, or with your patient. Saturations are like, SATS probe is obviously super useful as well. Like, it doesn't just show that you've got oxygenated blood, it shows that you've got enough pressure to make a waveform. Gives you your heart rate as well if for some reason your ECG's not working, so you can at least tell if the patient's brady or tachycardic. But then there is always that lull, it's the kind of 45, 60 seconds back, it's not real time monitoring. And sometimes, like last week, I had a patient where we had to intubate the patient who was, sick, and the ET tube didn't go in immediately, but it went in, and we got our CO2, so we knew it was in the right spot, new oxygen was being delivered, but the SATs then had dropped to 83 and they weren't coming up immediately. And so someone else who was watching this was like, your SATs are 83%. And like, we knew they were going to come up, but it's just that lag, So it just, at least with your CO2, you're in the right spot. You haven't put the tube in
And
the
it doesn't make any
esophagus.
noise, and you don't have to constantly fiddle with it for
Yeah.
positional. And like, I have a real thing about like white noise in the OR because, well, I'm sure you're aware that many of us lose our hearing over the years.
Yep.
And because you've got suction and you've got people talking and you've got this, and like in our case, we have things barking and so I'm like, if I could not have that like of the Doppler, then I'm more than thrilled to have that turned off. So.
Yeah, I usually have to. I don't know if it's because I'm getting older and I'm less tolerant to noise, but I usually turn the saturation tone down so that I can still hear it, but it's not super high pitched, because I feel the same. There's so much noise in the operating room that it can be, it's just a lot of input. It can be quite overwhelming. And when I last read about it, it's in human anesthesiologists for sure. I think it's like, was it 30-40% have some degree of hearing loss
Oh wow.
at the end of their
And
career.
that's right across the board, mostly
Yeah.
because of all of like the yowling and the barking and like all that kind of stuff. But
Yeah.
like being in the OR definitely doesn't help.
Yeah.
And I agree. The older you get, the more noise intolerant you become. Actually, Phil, our mutual friend, told me one day that I was going deaf and I needed to get my hearing checked because I wasn't, like, everything he said, I was like, what? Anyway, and I went to the audiologist and they're like, oh, your hearing is perfect. She was like, this happens a lot to people in their 40s. They come and they think they're going deaf, but most of the time they just don't care. And I was like, oh, okay, yeah, that makes much more sense. But yeah.
Yeah, it can be a very, very noisy place. Monitors, instruments, music, depending on your surgeon.
Yeah.
Yeah.
Mm-hmm.
I don't know if you guys play music in the operating room at all.
Oh yeah.
Oh yeah.
So do you always let your surgeons pick? Is that how it works?
Usually, yeah. Yeah.
So I have this thing where if the surgeon is faffing around and I want them to finish the case, and you know how some surgeons, when they talk, they take their hands out of, and they can't actually close and talk. And so I have two musical strategies that I engage because I have master control in the OR, which is one, no offense, Dr. Hamilton, but I'll blast bagpipe music. That's strategy one. And strategy two, as a half Austrian, I will blast yodeling competitions. And I find it really takes the chit chat down and drives like completion of procedure. Because I'll be like, the longer you take, the more I'm going to play this. So, yeah, I have musical strategy to completion. So,
Yeah, for us, it's usually the surgeons that pick the music. And I've got like some surgeons, love like the rock music. And there's one surgeon I work with who loves classical music. It's super relaxing. And you walk into the operating room and it's like, there's this lovely piano playing. But then some of our surgeons don't want any music played.
do you have any surgeons who are really into like the greatest hits of Walt Disney? Because I've known many Disney fanatics in my time, and like I'll pretend that there's some sort of patient crisis just so we can turn it off, right? Like I'll be like, no, I have to fix the blood pressure. Everyone turn off the Disney, because I'm like, I can't in the OR. I can't listen to The Little Mermaid. I just no.
I haven't heard it in the OR, but I remember, I think it was like 15 years ago, I was in Australia and a friend was having a house party and it got to like 4 a.m. and nobody was leaving. And he was at that stage where he was like, I just need to go to bed. So he got like a Walt Disney soundtrack and just started blasting it, like turned off the pop music, put on Walt Disney, full blast, and everyone just sort of stopped and looked around and then just started slowly like trickling out the door. It worked. So
Try the yodeling. That's my tip top tip is the yodeling really encourages people to shut the hell up and get the hell out. So
I'll try it next week and report back.
I'll say the Disney's definitely not going to work. The surgeon I work with is a dad, and he's got 4 children, and so he's well versed in all the Disney songs. So there have been a couple times where I walk in the OR and it's like Disney's greatest hits on Spotify or Pandora or whatever, and it's like, all right, cool. I'm gonna just go ahead and see myself out real quick.
Everything going well? Stable, patients alive? Yeah, okay, I'm getting a
I'll
coffee.
be watching through the glass window.
That's awesome. You can blast some baby shark, right?
Oh yeah.
Wow. That would be a lot. That would be a lot.
Yeah.
Yeah.
All right.
Your
What else
glasses
do
are
you-
off. Is that the end of the questions?
No.
You took your glasses off. I was like, oh, that wasn't that many.
So one of my colleagues asked, what do you think, maybe this podcast is a good example, but what do you think human and vet anesthesiologists can learn from each other?
Ooh.
Well,
I
got
think.
one.
Okay, go ahead, Bailey. Go ahead.
This is a really easy one, I feel, because this
Is
is
it
like
Alfaxalone? If you say Alfaxalone, I'm going to punch
no, it's not. This is the thing I think we can learn from the human side, in all honesty, is the recent, there was a recent paper about Teva use in veterinary medicine. It was a survey amongst trainees and board certified anesthesiologists. And overall, the comfort level was exceedingly low. And the main reason being that we were only exposed, so many of us were only exposed in, just going back to the conversation about Teva at the beginning, and comfort level was, we were only exposed for very specific cases, and it hadn't trickled over into like general population. So I feel like that is a area that we could definitely learn from the human side, because it's still like even in like academic circles, it's still a like not forbidden, but like it's still like, ooh, this is still like the cutting edge, and like
You have to excuse Ryan. He also went to a university that's stuck in 1984.
hey,
So
the paper,
that's why he loves the Doppler. He doesn't know how to use Teva, but
paper interviewed. I use Teva all the time, but the paper interviewed lots of other people though, and overall the comfort level was pretty low.
sad.
Yeah,
Yeah, I actually don't use Teva all the time. Use it for like certain indications.
Yeah.
So like the patient who's had severe post-op nausea and vomiting before, the surgery specific indications like the spine surgeries where volatiles interfere with your kind of neurophysiological monitoring. The patients with history of malignant hyperthermia. I actually don't know if that's a thing in animals.
Yes, it
Yeah.
is.
Okay.
Pigs,
Yeah. Yeah.
pigs for
Horses,
sure. It's a lot.
pigs.
Okay.
Dogs, but usually it's halothane related. So, and I mean,
Right.
Bailey probably uses halothane because he's from the 1900s. But
Oh my God.
yeah,
Come on.
it's pigs and halothane are probably our biggest indicators. But
Yeah.
you can technically see it in any species. I think
Yeah.
in dogs the subpopulation is Bernese Mountain Dogs. But
Mhm.
like I said, yeah. But
I
yeah,
don't think it's been reported in cats, or not reported reliably in cats. I don't
cats
believe.
just get opioid induced self limiting hyperthermia.
Right,
But
right, right. Not actual MH though.
no,
Yeah.
But I think with the Teva as well, and completely repeating myself, but again, it's just very specific to like where you trained and how you were trained, and what your center uses a lot, what kind of surgeries you do, and what's your comfort level as well.
see, that's the one
Yeah.
thing, Mika, just from having done human anesthesia rotation. And then we used to, at Cornell, we used to have, I guess, the R3s from the Weill Center in Manhattan come and rotate through us. And I think one of the reasons why they sent their residents to us and why they like to have us, and then oftentimes we would give talks while we were present, was because we are allowed to engage, I think, in a lot more like free thinking. So we have less standardized protocols. And also because we do such a variety of species, I guess like our lateral like problem solving or our aptitude for that is probably quite different. So classic example is, one of my mentors from Cornell was anesthetizing rhinos in Namibia, and they were studying which position is best to avoid hypoxia for when they move them between countries because of poaching. And they basically built like a rebreathing circuit for the rhino from like PVC piping that they found locally, because there's certain, like, it's not manufactured and they couldn't transport it, so they built it in Namibia. But the issue that they were having was with what to make the unidirectional valves in the circle, what they wanted to make out of it. One, it has to be something that obviously has like good movement, but two, it couldn't get highly contaminated with sand because they were in the field in Namibia. What they ended up doing was actually cutting out pieces of like the Land Rover's like seat leather, because the leather actually moved well and didn't trap sand, and you could also take it out and wash it. And so they cut their car up with a bunch of PVC piping to make like a research level anesthesia circuit. So yeah, I think, yeah, we MacGyver or we jerry rig a whole bunch more stuff than I think would be standard of care for you. Could probably get sued if you did this. Don't put it on the prep use. But yeah, like, but
Yeah.
yeah, so like we have a lot more like creativity out of necessity, not necessarily because we're inherently more creative. I don't mean to undermine human anesthesiologists, but yeah, I think that's one thing you guys could learn from us. And I mean, we hold a lot of physiological variables in our head. Just, who has a 2-chambered heart, a 3-chambered heart, who has, paired lung sacs, who oxygenates on expiration, who has hypoxic respiratory drive, like who goes into a diving reflex. And so we're usually like anesthesiologists and vet med are pretty hardcore physiologists for the most part. So I don't know. I think that's probably one of the things that when people like come shadow with us, and we, for example, in my hospital too, like I'll switch between small and equine just by walking down the hall. And like a lot of times they're like mind blown, because, horses are obviously very different from cats and dogs and what have you. So it's my 2 cents.
Well, I mean, when I was thinking about that question, that's actually what I came up with. Was, I don't know if adaptability is the right word, but that skill of just dealing with, like hundreds of different species, and different monitors don't work for different animals, and having to like pull things together and being in different places and just kind of getting on with it, if that's okay to say. Like you just have to.
Resiliency. Yeah, like we're a
Yeah.
little bit, yeah, we're more like Ryan loves to build PEEP valves from bucket of water. And like sometimes like most of us can probably build like a breathing circuit and
Mhm.
basic anesthesia machine just from like like one of those games, like a party game, like here's a bunch of parts, like build an anesthesia machine. Like, we could probably, most of us get away with that. And I'm not sure that humans could, because you guys all have like beautiful, like top of the line, state of the art, and everything is very like, protocolized and what have you. Whereas we're like a lot, sometimes when you're doing a case, you're like, someone's like, oh, have you done a lot of lemurs? And you're like, God, no, this is like first lemur I've ever done. And they'll be like, well, how's it doing? And I'm like, I have no idea. So I feel like we roll with like the unexpected with a higher resiliency. But then again, your patients talk, which makes me feel nauseous. So anytime the humans talk, like on the table, like during like C-sections and things, I'm like,
No, sometimes we have like some great conversations and you meet some really interesting people. So it's quite nice. But I'm thinking as well, though, like, I mean, you were talking last time about, trained veterinary anesthesiologists. And I'm just thinking about, obviously I work in Toronto and we have amazing resources and machines and equipment and safety monitors. But there are like many countries in the world where, again, there's not enough trained anesthesiologists to look after the population.
only 4 or 5 drugs are legal to practice with, right? Because like a lot of countries have significantly more stringent drug related limitations, a lot to do with like cultural beliefs and also like human dependency or the human addiction factor. But I mean, it can be really challenging to get opioids and ketamine in Southeast Asia countries, right? So yeah, I think that behooves us well. And I've definitely been in cases before where like people have called for advice and I'm like, okay, like I actually have to engage my brain to answer the question because their resources are so channeled into such a fine line that you basically have to make magic happen with like maybe 3 things. As opposed to like the entire toolkit to your, and I sometimes have to remind diplomates like who can be quite critical about things. I'll be like, if we're sharing like an educational platform or we're presenting at a symposium or whatever, and they'll be like, well, this is very basic or this is da da da. And I'm like, not everybody practices in like EU and North America, right? And if we're trying to, address global standards, you have to have that whole spectrum available to people who may only have like limited resources or limited access to specialists. So yeah.
Yeah, I wish we learned from human medicine. I wish we learned, how important, like, having some of the monitoring, right? Like, capnograph only made it to being a basic anesthesia monitoring equipment in the 2025 anesthesia monitoring guidelines. You know what I mean? Like, and people, yeah, and people were having these like discussions on some Facebook group about, like, I read a post at some point where somebody was like, so what do we do if if we don't have one? And I'm like, fucking buy one. You know what I mean? Like, you know what I mean? Like, there's people out there that spend like $30,000 on, like, digital X-rays, and then they don't spend, 5K on a monitor, or they don't spend $2,000 to buy, the capnograph module for that monitor. I'm like, one of them is going to kill your patient. The other one definitely doesn't. You know what I mean? Like, so I don't know. Like, I wish we, a lot of people in med, I think they take anesthesia as like,
Means to an
something.
end.
Yeah, it's something like they don't. They accept the fact that some of the patients die, right? They just accept it, and they're like, "Oh, it's okay. That some of them are gonna die." And I'm like, "That's not fucking
Our
okay."
mortality rate's like what, 10 times the human
In
rate?
dogs, is 1 in 600, and the last reporting humans is 1 in 400,000,
Yeah.
which is, it puts it at probably close to, like, you know,
And in
100.
rabbits, it's 1 in 10.
Yeah, yeah.
Because rabbits suck.
I, as someone who did research in rabbits for anesthesia, I remember.
Well, I think we hit our mark. Thank you so much for being. We are definitely looking forward to have you again at some point on our podcast. Maybe it would be cool to, like, have, like, even a couple of human anesthesiologists that do things a little bit different, and like a different, like, we can find some somebody on the state side, maybe you have the anesthesiologist CRNA kind of discussion.
Yeah.
We use a lot of our equivalent of CRNA, the veterinary technician specialist there. Their exam is crazy. It's almost worse than ours. So, it's some of the questions I heard from that exam, I'm like,
Yeah.
sure, cool.
Yeah.
But yeah,
Our anesthesia assistants go through quite a long training process as well.
oh yeah,
And yeah,
yeah,
but we have
it's
a great team of them in our hospital. So
that's crazy. Yeah,
yeah.
it's but hopefully we increase the numbers of anesthesiologists, and both in the human and in the veterinary world, and as well as the numbers of assistants, CRNAs, and VTSs in anesthesia. We definitely,
Mhm.
there is, our numbers are tiny, so and
Yeah, sounds like it. Yeah.
and our patients do need it desperately. So
Mhm.
hopefully we can change the mortality rate a little bit. Well, thank you so much, guys, for being here. I'll see you next time.
For sure.
See
Could
you
I just
guys.
also say as well, I'm just so happy that Ryan, a vet, used the word toe beans.
Yeah,
I was like, even vets say toe beans.
yeah,
Amazing.
for sure.
So thank you for that.
Glad I
That's
could help
awesome.
out.
Yeah. All
That's
right. Thanks
awesome.
again.
Thanks, guys. Have a good night.
All right. Bye.
Bye. Bye.